turning back to Dr. Antonoff and to Dr. Reckman, this is a really nuanced question. I really appreciate this question from the patient or caregiver that wrote it. For using local therapy in the setting of metastatic disease, there's this thought of can we radiate or should we resect all sites of disease versus should we really be trying to understand the biology of if this is behaving like oligometastatic disease? What do you make of that question and the nuances of pulling in local therapy?
I'm not sure I totally follow. So the question is, do we need to be sure that it's behaving
Is it really
biologically?
behaving like oligometastatic disease? Let's say a patient has more than what you can count on your hand, right? More than
Yeah.
five sites at the
Yeah.
beginning. Mhm.
So this is where we get into the controversy of whether staging really matters at all. So
Yeah.
staging is based on anatomic definitions as a surrogate for disease biology. And historically, staging was helpful because it told us someone's biology based on the volume of tumor and how long it had been there. That was what you found out by anatomy, is how long has it been there and how bad is it. But now we can not only interfere with biology, but we understand it better. And so, I mean, I would argue that the number of metastases doesn't matter. We've definitely oligometastatic disease was our breakthrough into doing, more aggressive therapy in terms of radiation and surgery. But if someone is responding in a way that shows us their biology is favorable and we are beating biology, then I think that's the window to radiate everything you can, take something out, be aggressive in that moment when we're beating biology and try to stay while we're beating it. I mean, for any of us who've spent time at our kids' sports activities, you know that once the other team starts to overcome, you just kind of give up and you hope that your kid isn't mad at the end of the day. But you want to fight while you're winning, not while you're losing.
Yeah, I think that's a great way to address that question. I mean, there's a lot to get at here. I'm going to try my best to be brief. We're still understanding pace of disease as well. For example, just because someone might have six brain metastases one year, that might not mean that they're going to have one the next year. I've had plenty of times where they have six one year, then none for many years, and then one a year later, then five, 4 years later. So pace has to do with this. And then
Mhm.
also, when we are delivering local therapy, when someone's on a medicine, the whole argument for this is whether or not it's isolated resistance in the spot that we can see on radiology. So that's like isolated clonogenic resistance is like the medical jargon, or is it global clonogenic resistance? As in, has all of it learned its way around that medicine? And so a lot of times we just have to give the benefit of the doubt. And if we believe that the treatment, the local therapy is safe, and it will be effective, then it makes sense to do, especially when folks might have limited subsequent options for medicines. I always just say, I want to keep my medical oncologist sleeves as long as possible with as many tricks up them. So, I mean, it's really complicated in terms of pace and whether or not everywhere has learned its way around the pill. And then otherwise, for example, I've had patients on KRAS inhibitors for years when we use local radiation. On the trial, it was 6 to 8 months. You know what I'm saying? And my
Yeah.
medical oncologist will say, I'm going to switch medicine unless you do local therapy. Right.
Yes.
But then I see very weird kinds of progression that's not caught on imaging. So that's where I think like these advanced biomarkers are going to really help, like circulating tumor cells to help maybe pick up things before they show up on scans. But I've lost dear friends who've had very unusual subclinical progression when we're doing local therapy and continuing the same medicines. And so I don't think we really know the answers to these questions, but I think they're critically important questions.
Yeah, thank you both. And as a medical oncologist, I really appreciate what you and Dr. Antonoff do to help us get more mileage out of the drugs that are working quite well, right, for patients. And so we really appreciate that.